I'm Demi Radeva, and this is the Akros Advantage. I'm joined here by Dr. Tim O'Connell, CEO of Intelligent. Can you tell us about yourself and your journey?
Thanks, Demi. It's a
Yeah.
pleasure to be here. Thanks for having me on. I'm a practicing radiologist. I work clinically 1 to 2 days a week. I'm based up in Vancouver, British Columbia. And before going into medicine, I used to be a network engineer. So I came into medicine and was sort of a little bit horrified as to the state of sort of how things, are working in the healthcare system and our lack of information technology and this sort of thing. And so along the way, I met some really wonderful people and said, hey, we have a lot of unstructured data in healthcare, and that unstructured data contains a lot of the answers we need to do our job better and safer and more efficiently. And if we can extract that, we solve a lot of problems for people. So that was now about 10 years ago, and we founded Intelligent, and we're pretty busy these days. There's a little bit going on with AI.
Yeah, well, thanks for being here. I'm very curious. So today we're discussing where AI meaningfully impacts payer and pharma economics and where it stalls operationally and what headlines often oversimplify about implementation. And so I'm curious, where do you want to start?
Oh my gosh. Yeah, this could be a very long podcast.
Right. Yes,
Absolutely.
I love it.
I think, so I think, one of the big issues is, there's a number of broad categories of issues. One of the big issues is getting access to data. Traditionally, payers had a lot of claims data, but they didn't necessarily have access to clinical data. Now they're getting more and more access to clinical data. And because that data is like in note form, like Tim came to see me today with a 3-week history of right knee pain, right? They can't necessarily access it. So they need AI tools to access that data to begin to use it for various use cases, right? Building better risk models, identifying patients for care plans, simple analytics, making sure that, that there's so much. Sorry, I could keep going.
I was going to say, should a payer even have access to clinical data? And isn't, claims data known as the gold
standard? Philosophically, which I'm happy to talk about from that perspective, if a payer can understand your health status better, then they can provide you with better care. So it seems to me, part of understanding your health status is understanding what's in your health record. And so if they can get access to the health record, they could provide you with, better care.
services.
Yeah. I think care plans are an amazing creation of the payers, and having a nurse call you every day to say, hey, what were your blood sugars this morning? What was your weight this morning? Did you take your medication? That can really make meaningful outcomes in people's health status. So those kind of plans are great. And I come from a country where we don't have those plans. Right. And so, I think I'm a pragmatist. Anything we can do to help patients along their journey is a good thing.
I was curious about the physician perspective because oftentimes I hear the opposite,
Right.
as in, we're the physician, we know best, we want to be in control. And so having other decision makers or having other sort of hands in the pot can sort of dilute things or make it harder to actually practice. But it sounds like having the opposite experience or functioning and operating in different systems, giving you a different perspective.
Absolutely. I think definitely that kind of patriarchal approach of the physician knows best is absolutely not the right approach for healthcare. I think hopefully we've proven that in many ways, but I think number one, patients should be responsible for their own care and who gets access to their documents. I think respecting patient autonomy is the most important thing. But let's be honest, most doctors are too busy, or it's not within their scope of knowledge or not within their scope of training. I don't think a doctor necessarily wants to call you every morning and say, hey, did you take your medication this morning, right? Yeah. So in that case, the people who are doing that work need access to your chart so they can know you before they call you.
So does AI know best?
Oh, that's a good one. I think there's a lot of people out there who think who've done brief experiments with it, who get very sort of like generally positive results. And they're like, wow, we could use AI for this. And yes, there's a kernel of truth there, but the devil's in the details, right?
Give me an example. I'd love to unpack it.
Yeah, for sure. So some of the problems with, I think anyone can take a medical document and paste it into a large language model interface and get some, what definitely looks like meaningful results. And certainly there's going to be lots of truth in there too.
And AI often does make it sound like very authoritative and like it knows what it's talking about.
100%. Yeah, the way I view large language models by themselves is sort of like a mature medical student. So it's wonderful. Now we have people entering medical school at age 30, at age 40. And as a radiologist, right, we work in the basements of hospitals and we see people come down in white coats and maybe they've got some gray hair and they're sort of like, well, I'm here to see you about, Mrs. Wong, and I'd like to talk to you about this thing. And then the conversation rapidly spirals out of control and you're like, wait a minute, are you the staff? And they're like, oh no, I'm a third-year medical student. You're like, oh, okay, let me teach you about what you need to know.
Yeah.
Right. So I think of LLMs like they're sort of a third-year medical student.
Oh, I love that perspective.
Right? They kind of like, they always sound confident, right? And they've got amazing fluency that you're like, oh, I could just read this all day. There's no typos. It's super well written, right?
Yeah.
But they have a propensity to, they want to please you. Right? They're very psychopathic. They can completely make up facts. It very much matters how you ask the question. There's a great study in Nature Medicine just this month showing that like the ability to identify medical conditions drops significantly depending on how you ask the question.
I'm going to have to read that. Yeah.
Yeah. And then, one of the other big issues with them is just that astounding fluency tends to make you believe them, right? So those are just some of the problems. It doesn't mean they're not a great tool. It doesn't mean we shouldn't be using them. But the question is how can we implement like safe and trustworthy AI? How can we make sure that we don't create workflows where there's not a human in the loop? This sort of thing, right? And benchmarking, so important, right? If it works well on one document, it doesn't mean it's going to work well on a million documents.
Oh,
right?
Interesting.
And so what is the error rate, right? Humans have an error rate.
Yeah.
AI is going to have an error rate, right? So is that error rate, if it's 10%, is that acceptable? If it's 1%, is that acceptable? Depends on the task.
So how do you take all of those insights and implement them in what you're doing at Intelligent?
Yeah, so we've been building language models and working with, machine learning, NLP, artificial intelligence for 10 years now. And I have the scars on my back to prove it.
Okay.
And so it is we've made amazing progress and we work really closely with our customers to understand, what is your problem? What are you trying to solve? And using machine learning models and artificial intelligence costs money. Is there an ROI for you? And is the ROI a financial ROI, an efficiency ROI? Is it a patient safety ROI? And so we're very careful in working with customers about understanding what they're trying to achieve and making sure that it's safe and making sure that we're happy with like how the output's going to be used and all that sort of thing. So yeah, we spend a lot of time with our amazing computer science team and our clinical team annotating documents and creating language models and assessing accuracy and this sort of thing so that, when customers come to us, we can quickly go, oh, this sounds like a task that's perfectly suited for us, or that may not be a safe or reliable task.
I'm curious on your perspective, where does the clinician perspective begin and end, and where does the technologist perspective or solutioning begin and end for some of these problems?
I honestly don't think there's almost any sort of beginning and end here.
Okay.
I think really it's almost a very right brain, left brain approach to things, right? I think having the clinician's perspective on how we're using data and what customers can expect is super important, but also knowing like the limits of technology, the costs of technology, the implementation hurdles that will be experienced. I think, and we've got an incredible team at the company. And so that's why I've got a lot of people I can call on to help me out in those conversations.
Okay, wonderful. When AI initiatives stall or when you're working with the client and implementing, is it more often technical friction? Is it organizational resistance? Or is it economic misalignment? You spoke about ROI.
Yeah, it can be any of the above. Right?
Okay.
I think one of the things that we really try to be careful of is avoiding what we call internally science fair projects.
Okay.
Right. And that's where someone says, oh, like, I wonder if this is something AI could solve.
Oh, okay.
Right. And
All
you're
right.
like, oh, okay, potentially it could, but as we engage with clients, we often ask questions like, do you have a machine learning review board? Is there an AI review board, right? Are they going to be reviewing this project, right? Because they probably should, right? And some customers, depending on the size of the organization, might even be like, well, I don't know, right? And so these are questions which we work with our clients to help them answer up front, right? As well, understanding scale and budget. One of the payers we're doing some work with recently processed like a couple 100,000 nursing notes using large language models, and the cost was close to $300,000.
Wow.
Right. And so it was very cost prohibitive for them. And they were.
I mean, we're talking at Vive, right? That AI is supposed to help us reduce the cost and make things faster, cheaper, easier. So that sounds like a huge bill.
Yeah, it's an enormous bill. I mean, the question is how many humans would it take to process that many nursing notes, right? And there'd be a cost associated with the time for that. Would it be less or more than that much money? I'm not sure. But still the question is for them, are they getting a $300,000 benefit out of gaining that information from it? And what can we do working with them to reduce that cost, right? So, as it turns out, something quite significant to reduce that cost. But those are the kind of questions that we have to go in and think about, like financial, implementation. Yeah. Some people have heard that maybe IT departments have rules and regulations, and so that is always a big thing, right? Is when we talk to customers, if it's an end user we're talking to, we'll be like, we need to talk to your IT people like upfront, right? Because they may have policies that we have to live by, right? There could be, even depending on the customer, it could be government regulations about handling of data, things like HIPAA, this sort of thing. So it's there's no easy projects.
So where does Emtelligent shine? I would love to hear some examples of projects that you've, worked on in health systems, at payers.
Sounds great. So really, I think the sort of advantage things that we try to bring to our customers, one is accuracy.
Okay.
So we're submitting a paper to an upcoming conference showing that we're like 12 percentage points higher than the current state of the art for doing one of the medical coding tasks involved in natural language processing.
Okay.
Right. Which is 12 percentage points higher is like a massive, that sort of thing usually doesn't happen.
Yeah.
So accuracy is one thing which is really important. Another is cost efficiency. So because we've been building our own language models for so long, and don't get me wrong, we love large language models. We use them for some things too, but not every task needs a large language model. And so having our own language models means we can set the price for our customers, right? And work with them to find out a pricing solution that works for them.
Okay.
Like, for example, if you go into a health system and say, okay, well, for analytics, we're going to process all your documents and we're going to do it on a per document cost basis. The hospital might say, well, like that's not aligned with our business models, right? We need to process all the documents to know what's in them, to do the analytics, and then that might help us save money. Whereas with a payer, you might be able to go in and go, well, every time we process a document, you make more money, right? So, maybe a per document processing use case in that case is appropriate. The other way which we help them is being able to deploy our software inside of their infrastructure. For many payers, information security is paramount. And so being able to say, yeah, you can operate our software inside of your environment. We don't have to be cloud-based. We can never see your data, right? We're obviously not going to use your data, this sort of thing. Then that brings that sort of significantly lowers a barrier to working with many payers.
You mentioned, all types of companies here being at Vive. I'm curious, and describing what you described, there's so many topics and problems that you're solving. Do you have a partner? Do you have strategic partners?
And we definitely do.
Where does Emtelligent begin and end, and how do you plug in?
Absolutely. Well, I mean, I think one of the best, we've got some amazing partners. We're often a white label solution for people. So, in that case, so
a doctor logging in or someone working at a payer won't necessarily know
that the data came from us, and we're totally cool with that.
Okay.
Right? We call that our MTEL inside strategy. Large organizations want to deal with as few vendors as possible, right? Obviously, from a vendor management perspective. And so we often work behind the scenes with our technology partners who are already servicing payers or servicing health systems, that sort of thing. And that arrangement works well for everyone.
Okay, wonderful. Is there anything you would like to share with our audience today?
Oh, no, just keep making healthcare better, please. Our patients need it. Our healthcare workers need it. Our, people who are paying for healthcare need it. Yeah, we need a more sustainable healthcare system.
And I'm curious, actually, before we wrap. I mean, again, you work in a different health system, and any thoughts that recommendations that you would give to us here in the U.S.?
Sure. So there's
Yeah.
absolutely nothing wrong with single payer healthcare systems, right? It's about how you implement it. There's lots of governments in the world who have single payer systems that are super efficient and have short wait times and deliver amazing care,
Yeah.
right? And there's also, for the people who live in countries like that, there's also nothing wrong with privately funded healthcare, right? That is a model that can work amazingly well, often because there's so much analytics that goes into asking the question, did we deliver the right care to the right patient at the right time at the right cost,
Yeah.
right? I work in a system where, yes, the cost of healthcare is to the end consumer as an upfront cost is very low, but we don't have nearly the analytics that we need to have to make the system efficient, right?
Yeah.
And
Wow.
so, I think people look at the Canadian healthcare system and say, oh, wouldn't it be great to not pay for healthcare? And it's like, yes, it would, but like our system has tremendous inefficiency that we need to fix. So there's no right answer. It's just like,
Trade-offs. Yeah.
it's all trade-offs. And can we, if everyone does their job well, then that's good healthcare.
Oh, amazing. Well, thank you so much. I really appreciate it.
My pleasure. Thanks for having me on.